Hi, you are in the ladies' room with Dr. Donica, the only public ladies' room you can enter anytime without ever waiting online. I'm your host, Dr. Donica Moore. We'll be having real conversations with real women about really intimate issues. They may be embarrassing, sad, or funny, but they will always be interesting and informative. You know, like the best conversations you've had in ladies' rooms with your best friends, or total strangers and a physician. Please join us. Hello, and welcome to another exciting episode of In the Ladies' Room. Now, for all of you who saw the title of this episode called The Talk and thought it was a sex talk, it will be in part because we're going to be talking about the Talk 2.0, the menopause talk. And of course, there's lots to talk about sex in there as well. But most of us have either given the talk or had the talk about the birds and the bees. And usually this is a pretty awkward conversation between parents and their preteens about menstruation and enough information about sex to highly discourage having it anytime soon. But that if you do, what proper precautions to take. And if not in middle school, some version of this talk is given in health class. But who do we turn to when it's time for the talk about menopause? Today's guest, Dr. Stephanie Faubion, advocates that all women should have this talk with their primary care providers or their gynecologists in their 40s. But we're going to do it on the podcast live today. Now, Dr. Faubion is the perfect person to give this talk. She's professor and chair of the Department of Medicine at Mayo Clinic in Jacksonville, Florida, and the director of their Center for Women's Health. In addition, she's the medical director of the North American Menopause Society. Her clinical research interests include menopause and sexual health in women. She's the principal investigator for the Data Registry on Experiences of Aging, Menopause, and Sexuality, aka DREAMS. She served on the board of trustees for the North American Menopause Society and the board of directors for the International Society of the Study of Women's Sexual Health. She also serves as an editor of the journal Menopause and is on the editorial board of Journal of Sexual Medicine. She's a graduate of the University of Texas at Austin and completed her medical school and residency in both internal medicine and pediatrics at the University of Texas Health Science Center at Houston. She subsequently earned an MBA at the University of Minnesota. Dr. Faubion, welcome to the ladies' room.
Oh, thanks so much. It's such a delight to be here.
Oh, it's a pleasure to have you. You know, I invited you because you and I, as you know, but not everybody listening knows, we were both panelists on the American Medical Women's Association webinar on menopause last week. And you had this great concept that you were talking about the talk. And I thought, wow, you know, I never really thought of it that way. But that's exactly what we need to do. So before we get into that, you know, we still are in the midst of a pandemic that's increasing every day. We had 5 days in a row of our highest numbers of new cases ever in the United States. How are you and your family doing?
Oh, thanks for asking. We are fine and probably going just as crazy as everyone else is locked in our homes. Yeah, I have 3 daughters who are 21, 23, and 25, and they're each in their own areas of the Midwest and experiencing cold right now.
Oh, well, at least they're not home.
They are not, exactly.
Mine came back.
Oh dear, yes, that's happening a lot too.
Yes. So we've had a lot of podcast guests talking about that interesting experience, but I'm glad everybody is healthy at this time. And of course, we're taping this on election day. So I hope everybody who is listening has voted. Tell us, what's the connection between voting and women's health?
Oh gosh, well, this election, I think it has a lot to do with women's health. But not to get too political, I think, you know, whoever's in office, it's going to make a big difference in terms of women's health in general. So let alone all the people in my office experiencing severe anxiety related to this election.
We did a whole separate episode on pandemic anxiety, but we didn't do one on election anxiety. So speaking of the relationship between politics and women's health, most of my guests answer that question with something regarding access. So we could have the best care in the world, which I think we do, but if you don't have access to that, it doesn't really help you. Speaking of access and menopause and coronavirus, there's been some very interesting data that's come out recently about the connection between menopause and coronavirus. Would you like to talk about that for a sec?
Well, I want to hear from you about menopause and coronavirus because I don't know that we have a whole lot of data on that. So please
So
enlighten me.
there is one large study that came out that showed that menopausal women, particularly age 50 to 60, are at increased risk of getting coronavirus, not dying from it, but contracting it. We don't know if that has anything, the data wasn't sliced and diced to see if that's an estrogen or hormonal thing or whether that's a caregiver thing. Because certainly many of us who are between 50 and 60, and I resemble that remark, um, are caring for, we're in the sandwich generation. So they haven't sorted out. And of course, many women between 50 and 60 are also essential workers.
Well, and I think another point would be we are losing estrogen during that time frame, and we have preliminary studies that I've seen have shown a connection between estrogen or lack thereof and risk due to coronavirus. So that remains to play out, I think.
Yeah, that's a really fascinating question. So what is menopause?
So menopause technically is defined as no menstrual cycle for 12 months. Typically, average age in the United States is 51.4 years, but anything after the age of 45 is considered normal. And most of us, about 95%, have been through this by 55 or 56.
Mm-hmm. So I always like to throw in no menopause or no menstruation for 12 months for no other reason. So that's in light of no pregnancy and no other reason. So of course, women who've had a hysterectomy or have had their uterus removed, if they still have their ovaries, they technically have gone, they don't have periods anymore, but they technically haven't gone through menopause if their ovaries are still functioning. So everything we say, of course, there'll be an exception. But right now we're going to talk about Menopause 101. Love your comment that we should have this talk. But who do you think should give this talk and when?
Well, I think women need to be prepared for this before they actually hit menopause. So ideally, I think this should happen just like we try to get the talk on the front end before we start our periods. I think it should be, in the early to mid 40s. As for who gives it, I think anybody should be able to give it who does any kind of primary care. So family medicine, internal medicine, gynecologists. I think everybody should be able to give the talk who's caring for women during that time.
And how do you start that conversation if you're the patient?
I think women need to be armed with knowledge, and when it's not that all women are going to understand that there is a change coming. Although I think most of us know this, right, intuitively, that there's something happening and something's going to happen, and it's happening to our friends, and it happened to our mothers. So I think women should ask the questions about what can I expect. It's just like the what to expect when you're expecting, right? Except we need to know what to expect when we're stopping. All this stuff is shutting down. So as a rocky a road it was for it all to get ramped up in the pubertal time frame, which was kind of crazy, it's just as rocky coming off that roller coaster. And for some women, and not all, I think we were alluding to this before we came on, that not everybody has a horrible time with this. We shouldn't say that. Some women literally have their last period and that's it. Nothing really happens. But some women struggle a lot, and I think it's important to let women know what's going to happen if they do stumble a little bit during this time frame.
Yeah, we say about 7 out of 10 women have some bothersome symptoms of menopause that interfere with their daily lives, but that means 3 out of 10 don't. My mother was one of the 3 out of 10 who had no symptoms whatsoever. And when she was about 55, she called me rather upset because she had a new gynecologist who told her she might have endometrial cancer for no reason. And when I calmed her down and got to the root of it, the gynecologist asked her if she was having any vaginal bleeding. And my mother said yes. And the doctor didn't ask her if that was a normal period. She just assumed that because she was 55, that was abnormal vaginal bleeding. So at that point, I had to talk about menopause with my mother and with her gynecologist.
Oh my, that's kind of embarrassing, isn't it?
It was very embarrassing. And then about a year later, my mother said to me, she called me up once and she said, should I be taking anything? And I said, can I have a clue what the topic is? What are we talking about? And she couldn't even say the M word. But lots of her friends were taking estrogen, and she wanted to know if she should be taking estrogen. So, that was a long talk. So how do you have that conversation with a patient? How do you make that assessment?
Of whether or not they should be taking hormone therapy?
Or anything?
Well, I think you got to start with, tell me what your experience is. Are you having hot flashes and night sweats? And this is very interesting because we're in the middle of designing a survey for primary care women here, asking about menopause symptoms, and everybody kept coming back to us saying, you got to tell them first that these symptoms are related to menopause because they're not going to know.
Yeah.
So I think that's part of the problem, is that not all women understand that, it could be hot flashes and night sweats, but most everybody has heard of those before. But not everybody has heard of, well, you can get palpitations, your heart racing. You can have anxiety symptoms and feel like you're so irritable and you want to just, claw everyone's eyes out. And I have some women coming in saying that they're afraid for their family members because they're so irritable. And it can be vaginal dryness, and it can be pain with sex, but it can be trouble sleeping, or, even joint aches. We're now discovering that joint aches are one of the most common symptoms that women experience during the menopause transition. So when you look at all of those individually, who would know
Right.
that those are all related to losing hormones around menopause, and especially if you just have a couple of the more obscure ones like joint aches, right?
Yeah.
So
Years ago, Oprah made a very big public deal about the fact that she was having these horrible palpitations, and no other symptoms. And she got sent to I think she went to the Cleveland Clinic to get worked up for heart disease. And, lo and behold, it was perimenopause. So tell us the difference between perimenopause and menopause.
So perimenopause is just that time frame leading up to the menopause transition where your ovaries might not be producing the same amount of estrogen or as regular a schedule as they were before. So I always tell my patients, your ovaries don't turn off like a light switch. And I had one of my male colleagues describe the female ovary in perimenopause as like a boat motor sputtering. And I went, oh, dear God. A male description of a female body part. And then I thought about it, I go, dang it, he's kind of right. They do sputter, they do flicker or flutter or sputter or whatever you want to think of, a candle fluttering even. They don't go off like a switch. So they kind of work sometimes, and then they don't work sometimes, and you might go several months and everything's fine, and then you might go a few months and you're sweating and flashing and irritable, and then they might be fine again. So it really is this period of hormones rocking around, and we know that it can last, up to 6 to 10 years, a long time. So some women really have this roller coaster ride for a few years before everything stops.
Yeah, what I often say about perimenopause is it's menopause's evil younger sister. And it just all depends on everything. Or I say it's like adolescence in reverse. And we all remember how much fun that was. And yet there's some people who sail through adolescence without, too much difficulty or too much apparent difficulty. I was actually 55. And, we also often tell women that your experience is very likely to be similar to your mother's if everything else in your life is similar. And how many of us have everything else in our lives similar to our mother's lives? But I was 55, and so my mother had been 55, and I was sailing through menopause, and I thought, oh, this is great. I'm going to have the same experience as my mother. And little did I think about the fact that I was taking a medication for back pain, for back problems. I was taking Neurontin for nerve pain associated with the back problems. And I totally forgot as a doctor that Neurontin, even though it's not FDA approved to treat hot flashes, can actually suppress hot flashes and other menopausal symptoms. It's one of its bonus benefits. And so when I went off the Neurontin that week, I got clobbered.
Oh, no. Yes. Well, my mother asked, I wrote the menopause book for Mayo Clinic, and my mom said, why are you writing that book? And I said, well, that's an interesting question, Mom. I never really asked you what your experience was like. And she said, well, I may have had a hot flash once at a cocktail party when I had a glass of wine. And I said, really? That was it? And so I said, well, that's not the experience that a lot of women have. And so she didn't even really get the whole concept of why we would talk about this.
Mm-hmm.
So
Well,
it's interesting.
interestingly, I used to give a lecture called The Tale of Two Mothers. And I would introduce the subject by talking about my mother's experience, which I already shared. And my mother we should all be as healthy as my mother. She is fit. She exercises every day. She had 6 children all through natural childbirth. She's amazing. She's petite and powerful. And positive. But the other mother in my talk was my mother-in-law, who was not that way. And she had what I call menostop, where she did go into menopause in one day because she had a surgical menopause. And she had when she was 40. So she had a horrible, horrible, horrible experience. And, called me up one night and said, if you don't put me on estrogen, I'm going to do something irreversible. And she was calling me because her doctors wouldn't put her on it because she had had breast cancer. So that's a whole nother story. But the point being, it all depends on everything. It all depends on what your risk factors are. It all depends on what your fitness is. It all depends on what your genes are. It probably depends on the phases of the moon. It probably depends on whether you even notice that you're having these things or not. It depends on how well you sleep. And of course, that's a vicious cycle because all the surveys I've seen about the symptoms that women find the most bothersome is that sleep deprivation is the most bothersome. And for me, that's what pushed me over the edge. And I was on estrogen as fast as I could dial 1-800-gynecologist.
But you're right, it is all over the place. And I think what women find bothersome is also different for each woman. So some women find, actually, we did a survey in our clinic and looked at several thousand women that were in there, and the most bothersome symptoms for them were the mood symptoms and the weight gain. So even over the hot flashes and the night sweats, which were the most common, women were most bothered by weight and mood issues.
All right, so let's talk about the weight gain then. What is the real actual truth about weight gain in menopause?
Yeah, the truth is it's complicated. And it's complicated because the weight is a factor of both aging and menopause. And so if you really kind of break it down, it's probably a little more aging than it is actual menopause, but there are some menopause changes in there that are really important too. So we know that both men and women gain weight in midlife. And on average, we gain about 1.7 pounds a year in midlife as women. And while that doesn't sound like a lot, you put it over 10 years and it really starts adding up and it's hard to get off.
And throw in a pandemic and then you have to add 19 more pounds.
That's exactly right. And so it's a combination of we're not burning as many calories, so our metabolism does slow a little bit. Plus, we're losing a little bit of muscle mass every year after the age of 50. So almost 1% of our muscle mass after age of 50 for every year. So muscle burns a lot of calories. And when you're losing a little bit of muscle mass, you're not burning as many calories when you're sitting or when you're exercising. So I have women coming in, and I know you do too, and they say, I haven't changed anything and I'm gaining weight. I'm still eating the same, I'm still exercising the same. And I say, yes, if you haven't changed anything, you will gain weight. And I think this is one thing that's important in the talk, as we need to prepare women for this change, because when you think about it, this is one of the biggest cardiovascular risk factors going forward. Your weight goes up, your blood pressure goes up, your cholesterol goes. It's just this vicious cycle that leads to higher cardiovascular risk as we go through menopause. But back to the weight for just a second. So the other part that is menopause related is the fat distribution. So we all know that after menopause, we get this belly that was never there before.
I call that the menopot.
Yes, and the fat redistributes from where it was before to the midsection, and it is incredibly annoying. And that does seem to be estrogen related. they've done studies where women on hormone therapy have less belly fat than women not on hormone therapy. We do know that's kind of an estrogen effect. So the bottom line is it's a combination. It's probably aging and a little bit of estrogen loss too. But I always tell women that estrogen is not a weight loss drug, so don't expect to go on estrogen and lose a whole bunch of weight because that does not happen. Is
Right.
that your experience too?
Yes. And with all due respect to my mother, uh, most women, as they age and as they transition through menopause, are not doing the same amount of physical activity and are not eating
Yes.
the exact same way they did before menopause for whatever reason. So it is often difficult with these studies to sort out what is an age related effect, what's a lifestyle related effect, because
Yes.
there are certainly many women now who are working well past menopause. And so their lifestyle isn't really changing. But for women whose lifestyle has changed significantly, their amount of physical activity may change significantly in one direction or another. And so it's difficult to sort those out. So one of the things I try to do is talk about two buckets of issues. One is the symptoms, which we've already talked about. And I sort of categorize those as sort of the nuisance effects of menopause. But the other area are all the things that women, all the serious conditions, some of which you've mentioned, that women become at increased risk for once they go through menopause. And part of that's a menopause thing, part of that is an aging thing. So you talked about heart disease, okay, which is, of course, number one killer of women and men. And you
Yep.
talked about some of the risk factors for heart disease, which also increase. So you want to go through those again?
Yeah, absolutely. So our blood pressure goes up after
Mm-hmm.
menopause. It's well documented. That probably has something to do with losing estrogen, actually.
Mm-hmm.
But blood pressure goes up. Cholesterol is less favorable, so the bad cholesterol goes up. The good cholesterol tends to go down. We tend to gain some weight. There are the other cardiovascular risk factors. Some aren't things that we can control, like family history, but we can control some lifestyle factors like smoking, for example. Diabetes is also a risk, and our with that weight in the midsection, our diabetes risk goes up too. But I also just want to bring up we call them the nuisance symptoms, and that could be like the hot flashes. Hot flashes are a marker of heart disease risk, and I think we need to make sure that women do understand that these are not necessarily benign, and we're starting to find out that some women with certain patterns of hot flashes tend to be at increased risk for heart disease. And so
And what
it could
patterns
be,
are those?
well, they're different in different studies, so it hasn't really been absolutely determined, but it appears that if you have hot flashes that are severe, that are well before the menopause transition, well before your last period, it seems to be a higher risk. That they found that in the SWAN studies. So I think more to come on that. I think we need a better risk prediction model of heart disease for women, because right now we use the men's prediction model and it doesn't work so well for women. So I think we need to start incorporating some of these female specific things like hot flashes, like the timing of menopause, like high blood pressure during pregnancy, like diabetes during pregnancy, that are these female specific markers of later heart disease risk. That we might be able to get better at saying which women are going to have heart disease. Because as you said, this is the number one killer of women.
So one of the markers we talk about for women and men, but probably more commonly in women, is metabolic syndrome. So
Yeah.
I think that's very confusing to a lot of people. So would you like to explain what is metabolic syndrome and how does that play into all this?
Well, metabolic syndrome is basically just a conglomeration of the things we just talked about. So it's increased weight around the midsection, it's insulin resistance. So it's kind of that pre-diabetic state where your sugar's starting to go up and your insulin is going up. It's elevated blood pressure. It's your cholesterol and lipids don't look as good as they used to. So it's this combination of the factors that we were talking about that start to happen to a lot of women after menopause that combined really play into increased risk for us in
Okay.
terms of heart disease.
So in terms of other systemic diseases, what are the other things that increase in risk for most women once they go through menopause? And we've pretty much covered heart disease.
Well, unfortunately, breast cancer is goes up with age. So that's one thing we need to watch out for. And, we can talk about breast cancer and hormone therapy for probably another hour. That is a very confusing picture. But, our risk of dementia goes up. And that appears to be more in women than in men. And it probably is not just the fact that we live longer. We probably have a little bit higher risk of dementia as well.
And when we
So
talk
lots
about
of factors.
dementia, we're also including Alzheimer's, which is the most common form of dementia.
Absolutely. But our risk of atrial fibrillation is higher than in men. Our risk of heart failure is higher than in men. So there's really a lot of things that are unique to women, or more common in women as we get older, that we haven't completely sorted out yet.
Mm-hmm. And then also our risk for colon cancer increases after menopause, ovarian cancer, and of course, osteoporosis, which we talk a lot
Osteoporosis
about,
is a big one.
bone loss.
Yes.
And that is, that's a very good model for talking about the risk of menopause, because in the case of osteoporosis, we do know that estrogen is protective against bone loss. So I think there we do probably have more information than, in all the other categories.
Well, we've got a lot of information in a lot of those categories, but yeah, absolutely. When we go through menopause, we lose the majority of the bone we're going to lose. We lose in the first 5 years.
Mm-hmm.
So the steepest drop in our bone density is in the first 5 years after we go through menopause, and it levels out a little bit after that. It's still a downward path. But I think, that just speaks to how important it is to pay attention to our health in midlife, because what we're doing now is going to impact us when we're 80 and 90, right?
Mm-hmm. And hopefully we'll get to 80 and 95.
Hopefully
So
we'll
a
get.
patient comes and talks to you and they have a laundry list of symptoms or complaints or issues. How do you decide what to recommend to do about it?
Well, I think, as you said, it comes down to what symptoms a woman has and how much they bother her and what her medical history is. And what we know after sifting through all of this information that we've gotten from the Women's Health Initiative trials and the other trials on hormone therapy is that for most healthy women who are between the ages of 50 and 60 and within 10 years of going through menopause, the benefits of hormone therapy typically outweigh the risks. So that is a very broad statement, but what it takes in the office is, what symptoms are you having? How bothersome are they for you? What is your medical history? And are you a candidate for hormone therapy? And is that what you prefer? Is that your personal preference to take hormone therapy? So those are some of the questions. And while I put those out there in a few seconds, it probably takes an hour to go through most of that.
Right. Well, I think it also depends on what information the patient is giving you. Obviously, if a patient says, I don't want to take hormones, and this is very similar to the contraception talk, ironically. If somebody says, there's no way I'm taking hormones, I want something natural, or I want, an alternative to that, your conversation starts in a very different place than a woman who says, am I a candidate for hormone therapy? One thing I do want to make clear, though, is that when we're talking about the term, hormone therapy, what are we actually talking about?
Well, that's a very important point you bring up, and that is that not all estrogen and progesterone should be lumped into the same category. And we need to start being very specific about what we're talking about here. So when we're talking about hormone therapy, we're talking about those hormones that our ovaries used to produce. We no longer call it replacement therapy, because we are not actually trying to replace what the ovaries made. We're just trying to give enough back to reduce symptoms, to make them tolerable. So I think that's one important point, because we're not trying to put you back to age 20 with the hormones that we're giving. But there are many different types of hormones that can be given. We prefer the FDA approved variety, meaning that the hormones that have already been tested and approved by the FDA and are available in your local pharmacy, as opposed to the compounded variety. which a lot of women have resorted to because there's this perception that they're somehow safer and more effective. And that's a whole other
Well,
hour-long
so now you have to explain to
conversation.
people what compounded means.
So compounded is when a pharmacy can mix hormones in the pharmacy or in a lab and make them in whatever vehicle you want them in. So they can put them in olive oil, or they can put them in pellet form, or they can put them in a trophy that you put under your tongue. So many different forms. Now, there are some reasons that we would need to compound some hormone therapy, and those include, say, a vaginal estrogen cream, and you're allergic to the component, the cream that it's in. That would be a reason to compound. But for most of us, there are the doses and the forms that we could possibly want available with the FDA-approved varieties in your local pharmacy. So for the most part, there's very little reason to compound hormones. And we know that they're regulated. So for purity, potency, efficacy, and safety, there's lots of documentation when you go through the FDA-approved route.
Right, and quality control. So, so just to kind of wrap up that question of what are we talking about when we're talking about hormone therapy, we're not talking about one drug. We're talking about different hormones. We're talking about different types of those hormones. We're talking about different doses, and we're talking about lots of different preparations. So pills, patches, creams, gels, suppositories,
right,
etc.
Those
So you, of course, we talked a lot about estrogen, but you, of course, threw out progesterone. And I think that's what a lot of women are very confused about too, is like, where did this other hormone come from? And how does this fit into the whole picture? And why would I need progesterone if my body is not producing enough estrogen?
That's a great question. So our ovaries used to make progesterone as well. And there are functions of progesterone that are probably well beyond reproduction, but the progestogens are best known for their role in reproduction, and parts of the menstrual cycle are controlled by progesterone. The reason we give it to a menopausal woman, though, is when she has a uterus and she takes estrogen by itself, it can increase the growth of the lining of the uterus and increase the risk of uterine cancer. And so for those women with a uterus, it's necessary to take either progesterone or a synthetic variety to help protect that uterine lining from growing too much. If a woman has had a hysterectomy, however, she can just take estrogen by itself for management of these symptoms and doesn't actually need the progesterone.
So there's no added benefit that we really prescribe progesterone for other than reducing the risk of endometrial cancer.
That is true, although you probably get some added benefit out of the progesterone in terms of it has a sleep benefit, which is why we dose it at night. And it does actually in medical studies has shown to reduce hot flashes by a little bit, but not compared to the degree that estrogen does. So for the vast majority of women without a uterus, there is no need for progesterone.
Okay, great. So for the woman who says, I've read all these bad things about hormones. There's no way, no how. I'm not interested in hormones. What else you got, doc? Yeah. And let's just say this woman is symptomatic and she's within, 1 year of menopause. How do you approach helping her?
Yeah. So we do have some prescription non-hormone therapies that are available. And let me first just say that almost everything you can get over the counter has never been proven to work. So for the most part, you're making expensive urine, and you really just don't need to do that because unfortunately we're not there yet in terms of any herbs or supplements that have been proven. But there are some prescription therapies that are non-hormones that have been proven to have some effect. And when we talk about this, it's really important to note that hormone therapy with estrogen reduces hot flashes and night sweats by about 90-95%. Mm-hmm. But these other medications that are non-hormone varieties, they reduce hot flashes by in the range of 40 to 50% for the most part. There's one called oxybutynin that got to about 75%. But it's important to note that if I gave you a sugar pill, In a hot flash trial, it's worth about a 30% reduction in your symptoms. So any hot flash trials that we talk about, we look for a response over at least 30% because you can get 30% with the sugar pill. So somewhere in the range of 40 to 50% you can get is probably a little bit over a sugar pill, but not anywhere near that we can get with estrogen. Now, some of those classes of medications, you mentioned you were on some gabapentin for your back. That's one of them that has some data to show that it does work a little bit and it does take the edge off. So for women who have back pain or who have migraine headaches, or who are having trouble sleeping at night, gabapentin can be a good option because it really does make you sleepy. That's one of the side effects. One of the downsides of gabapentin is weight gain, so we've got to watch out for that. Their antidepressants work a little bit too, and for women who are having a lot of anxiety or depression symptoms, that may be an option. And we studied oxybutynin, which is a bladder control, an old bladder control drug that's been around forever. And that also has an effect. So for women who have overactive bladder symptoms, then that could be a good choice for someone. So we kind of tailor it to what else the drug might do for us. So we try to get a twofer out of it when we're using a non-hormone drug.
So one thing I do want you to address, because I want to point out to everybody that when we talked about the different diseases and disorders that increase around the time of menopause, we did not talk about depression. Because the studies have not really shown that for women overall, primary depression increases as a result of menopause per se. There are some women, of course, in certain subcategories who do have an increased risk of depression, particularly women who've had a history of postpartum depression, women who've had depression, major depression before, women who had severe PMS or PMDD. But for the most part, I think most women are approaching menopause as like, this is a time of celebration, or what Margaret Mead called the postmenopausal zest, as opposed to, the mother sitting there crying because of empty nest syndrome. Most of the women I know are partying when it's empty nest syndrome time. However, I want you to really drive this point home for people. Why do we give women antidepressants to treat menopausal symptoms if they don't have depression?
Well, because the drugs have been proven to work. So in trials, they do reduce hot flashes by somewhere in that 50% range. So they have been shown to be effective. But it's also important to note that some women really do struggle with mood around that perimenopausal menopause transition time frame. So for those women, this could be a good option. For the ones that are struggling with anxiety or depression.
Especially in the pandemic.
Yes, exactly.
But I do want to just drive that point home because I know a lot of women have contacted me very hostile and angry that they feel that their doctor is not believing them about their symptoms and they're thinking that it's all in their head. And I say, why do you think that your doctor thinks that way? And she says, well, because she put me on an antidepressant. Well, that's because that also treats those conditions. And even as far as back pain, antidepressants have been shown to be synergistic with other pain medications to improve pain syndromes. So that's another bonus.
And I would submit to you that a lot of primary care doctors out there are using antidepressants when they could be using hormone therapy. Because I think they're afraid of it. And to be honest with you, we don't know the long-term effects of using antidepressants for a long time. So I think, they're not necessarily benign.
Right. And they have a lot, one of the things I say in almost every podcast episode is that any medicine that is strong enough to have an effect is certainly strong enough to have side effects. And sometimes we know what the side effects are. So we know that one of the side effects of estrogen is that it increases your risk of endometrial cancer. And in those cases, sometimes we have an antidote for that, as in progesterone. But many times we don't know what the side effects are, or we don't have an antidote. So I had to go off Neurontin, for example, because of one of the most common side effects, not the weight gain. I was dealing with that. I was just suffering. I was just eating more to deal with it. But I had some short-term memory loss,
Yeah.
which is a known documented side effect of Neurontin. And I wasn't really aware of it when it was happening because I forgot. So that was kind of an interesting, an interesting observation that I made on my own. Anyway, I could talk to you about this all day, but we're running out of time. So I just want to ask a couple of personal questions. In your introduction, when I introduced you, we talked about how you trained in internal medicine and pediatrics. How do you go from training in pediatrics to being a menopause expert?
Yeah, that was a long pathway, right? So when I graduated from residency, everybody was pushing me into women's health. And I was like, no, no, I do not want to go into women's health. They said, well, of course you're going to join the women in women's health. And I'm like, nope, I'm not. And then when I arrived at Mayo, they said, well, of course you're going to work in the breast clinic. And I go, nope, I'm not. And so I really resisted going into women's health because that's where everyone wanted me to go. And so I practiced general internal medicine for many years. And it wasn't until the Women's Health Initiative study came out in 2002 where women couldn't get hormone therapy and they were being denied access to management of their menopause symptoms
Mm-hmm.
that it got me enraged, basically. And I had to get mad to be able to really want to go into it, and then I was absolutely passionate about it. So we ended up starting our women's health clinic in 2005. It took us that long to get it together, and it's been a passion ever since. And so I think once you get into it, and you're in the same field, so you understand that there's still so much we don't know about women's health because we haven't studied it in women. Heart disease, drugs. There's only one drug that is differentially dosed for women because we found out it affected women in a different way than men, and that's Ambien. But all the other drugs out there, they haven't been studied in women. We're still in our infancy of being able to figure out how women are different from men and how they should be treated different from men. So we're taking baby steps here, but we got a long way to go.
So when I read the thing about internal medicine and pediatrics, I thought about a comment that Dr. Robert Lindsay had made years ago. He was a past president of the National Osteoporosis Foundation. And he used to say that osteoporosis is a disease of pediatrics manifested in geriatrics. Because of course, most children are not drinking enough milk long enough to really establish sufficient bone density. But before I let you go, I want to also ask you one question I ask all our guests, and that is to share with us the most unique, interesting, or memorable experience you ever had in the ladies' room, aside from this interview, of course.
Well, I had a debate with a researcher in the ladies' room about the findings of the study and why they didn't report them differently. Yeah, that was an interesting bathroom discussion. I don't know. Tell me about one of yours.
Oh, well, you have to listen to episode 1 of our podcast where I talk about some of my greatest hits in the ladies' room. I think for the purposes of this conversation, one of the stories I shared at that time was in about 1989. I was in the ladies' room at the Adams Mark Hotel in Philadelphia during the American Medical Women's Association convention. And I was in the stall and I heard 3 other women debating about this issue about most drugs not having been studied in women than men and how they wanted to form a society to focus on this. And so, of course, as I was washing my hands, I joined in the conversation. I had no idea who these women were. They had no idea who I was. And by the end of the conversation, they invited me to join the board of this nascent organization. And it was the Society for Women's Health Research, which at the time was called the Society for the Advancement of Women's Health Research. So that organization was essentially born in a ladies' room.
Love it. That is fantastic. What a great story.
And that was Phyllis Greenberger, Marie Bass, and Dr. Florence Hazeltine in the ladies' room.
Fabulous. Absolutely fabulous.
But that was a good way to throw it back on me once I asked you. I saw what you did there.
Exactly.
Do you have another story to share with us?
Not a bathroom story, no. I'm
Okay.
sorry.
Well, we'll let you think about it, but I like the researcher one. And, I think that more and more we're having these sidebar conversations at conferences and, and in hospitals and in our jobs, and with not only with other researchers and other doctors, but also with patients that can, really influence how we think about different things. So any final comments on menopause? How does a woman know which one of her doctors to go to talk about this?
Well, I think she needs to go to who has some knowledge about it. And just a plug for the North American Menopause Society, we do have a certification program where we put doctors through an educational course content and offer them a test to acknowledge that they have this menopause related expertise. So women can actually go to the menopause.org website to look up a provider that has this certification and find someone in their area. So if your provider, whatever type of provider you have, if they don't have the information you think they should have, then that's time to seek out some help elsewhere.
I think that's great advice. The most important thing, of course, is to have a regular healthcare provider,
Yes.
to have a primary care health provider, whether it's your internist, family practitioner, your gynecologist, whoever you feel like you have that rapport with, and begin there. And then if that's not sufficient, then you can move on and find other resources. And so thank you so much for joining us. We really appreciate it. And I'm sure that many women will be rushing to the NAMS site. You want to tell us what the NAMS website is again?
It's menopause.org.
Easy enough. Anyway, thanks again. Take care and stay well.
Thank you. Enjoyed it.
That's all we have time for today. But let's keep the conversation going on Twitter or Facebook at Dr. Donica. Please join us next week for another episode of In the Ladies Room with Dr. Donica. Real conversations with real women about really intimate topics.